Hi there. My name is J.C. Villasboas, and I'm a consultant at the Division of Hematology at the Mayo Clinic in Rochester, Minnesota. My clinical practice is focused on the treatment of patients with lymphoma, bone marrow transplantation, and cellular therapy. And in our laboratory, we study the interaction between the patient's immune system and the lymphoma cells. Today, I'd like to talk to you about the patient who has a new diagnosis of follicular lymphoma. So if you have been given this diagnosis, I wanted to know 4 main points that are important for anyone who has received such a diagnosis. The first point is if you have been rendered a diagnosis of follicular lymphoma, or any lymphoma for that matter, I think you deserve to be seen at a center with specialized care for patients with lymphoma. It's important for you to understand there are nearly 100 different subtypes of lymphoma, and the diagnosis between these subtypes sometimes is very nuanced. So one of the things that I will always ask is the review of any external pathology, just so that pathologists with expertise in looking at biopsies with lymphoma have reviewed that diagnosis and have signed off on that as a correct diagnosis. The second point I want to make is that you have adequate staging, which is the determination of the location of the lymphoma throughout your body. This typically includes a bone marrow biopsy, a PET-CT scan, and blood work, in addition to a complete physical exam. It is very important to determine in which locations throughout the body the lymphoma is present, because this will help us understand which of the tests are necessary to be repeated later if you go through treatment. It is often common for patients to have a CT scan and not a PET-CT scan after a diagnosis of lymphoma, but the information provided by the PET scan is superior to that only provided by a regular CT scan. Additionally, some patients have silent disease inside their bone marrow, which is not visible through CT scans or even PET scans. And for this reason, I typically recommend at the first time of follicular lymphoma diagnosis that we obtain a bone marrow biopsy, because that can make a difference between diagnosing someone with stage 2 or 3 follicular lymphoma as opposed to stage 4 follicular lymphoma if there is involvement of the bone marrow. And we know that the stage correlates with the prognosis of the patient, meaning the likelihood that they will do well in the future. The third point that I want to make is that if you have been given a diagnosis of follicular lymphoma, I strongly urge that you have an assessment of the status of your immune system. We know that follicular lymphoma incidence, meaning the likelihood of diagnosis, increases steadily with age, with the median age of the patients at being 65. So it is more common to have a diagnosis of follicular lymphoma the older we are. The reasons for that are poorly understood, but one of the main hypotheses is that the aging of the immune system leads to the emergence of follicular lymphoma. And for that reason, I always try to have patients assess the status of their immune system prior to initiating any treatment for follicular lymphoma, because many times they already arrive in the clinic with an unknown, undetected immunodeficiency, which is important to know because sometimes we attribute the immune deficiency to our treatments when in fact the patient already had that deficiency prior to initiating any therapy. The third point that I want to make is during the initial evaluation of a patient with follicular lymphoma, one of the most important things we have to do is to rule out the presence of something called histological transformation. Histological transformation is the medical term that describes when a patient with a slow-growing or indolent lymphoma transforms its biology into a disease that is more aggressive and oftentimes life-threatening. In the case of follicular lymphoma, that transformation typically occurs towards something called diffuse large B-cell lymphoma, or DLBCL. Diagnosis of transformation is done by putting together a number of factors. One of them being the clinical presentation. So patients with transformation will often explain that they have a lymph node that has grown out of proportion to the other lymph nodes. So as if one chain of lymph nodes took off and started growing faster than the other lymph nodes. Sometimes they can present with constitutional symptoms, such as drenching night sweats, significant unintentional weight loss, but those are not required. Sometimes we can hint at a transformation by looking at their baseline blood tests. And finally, on review of the PET scan, sometimes a transformation can be hinted by seeing a lymph node chain that is disproportionately more active compared to the other lymph nodes. We expect, therefore, in a patient with follicular lymphoma that they may have multiple lymph nodes throughout their body, but their activity level should be homogeneous, meaning they should be about the same in different areas and not one particular area being more active. One of the common mistakes that I see when I evaluate patients in my clinic with follicular lymphoma is that the patient has multiple lymph nodes throughout their body. Let's say lymph nodes on their neck, under their armpits, but also in their abdomen. And at the first time the patient is evaluated outside, they reach out and get a biopsy of the most convenient lymph node, let's say the one in the neck or under the arm, because that's easy to do with an ultrasound. But when I review their PET scan, I notice that sometimes their most active lymph node is actually internal, inside the abdomen, which is not easy to reach. In that case, the diagnosis has not been completed, and it's possible that this patient could have missed a histological transformation. And in fact, they already have a disease that is more aggressive and more concerning than the follicular lymphoma that is under their armpit or on their neck. So in that case, a repeat biopsy may be necessary. And that's the point where having that pathology review is extremely important, because many times, depending on the area of the lymph node that you sample, you may see just follicular lymphoma cells, but if you look at another area, you can actually see these larger cells, which is consistent with this process of histological transformation. The fourth point I wanted to make, in case you have a diagnosis of follicular lymphoma, is that the treatment strategies are evolving rapidly. At this time, there are many patients who don't need to be treated. This is called watchful waiting or observation. And this is the case, for example, of a patient who comes to the clinic with an incidental follicular lymphoma, meaning they went to the ER, for example, to have a kidney stone assessed. And while in the process of getting a CAT scan, they noticed there's a small lymph node inside their abdomen. A biopsy, therefore, shows follicular lymphoma. In this case, a patient had no symptoms of follicular lymphoma, and the lymphoma was completely found by accident. Sometimes this is a patient who can be easily and appropriately observed without active therapy in the strategy called watchful waiting. In other times, the diagnosis of follicular lymphoma generates significant anxiety, or it comes with symptoms. And even if the lymph nodes are not big, this patient may need to be treated. In the patient that needs to be treated, we typically have a menu of options to choose from. Options including single-agent immunotherapy with rituximab, or a combination of rituximab immunotherapy with chemotherapy, which we call chemoimmunotherapy. But I want to stress the point that the landscape of treatment for follicular lymphoma is rapidly changing. And as of right now, we're moving agents to the front line that are more active than the agents that we currently have available as standard of care. So I believe that a patient with follicular lymphoma should be offered a clinical trial when they need treatment. So I urge you to seek medical attention at a place where you can be offered such options. One such option that we currently have being tested throughout the country is the use of bispecific antibodies, which are novel immunotherapy drugs that seem more potent than standard immunotherapy. And these trials are running throughout the United States, and patients are being randomized to the standard immunotherapy, rituximab, against this novel immunotherapy strategy with bispecific antibodies. Additionally, there are anti-lymphoma vaccines being tested for patients with follicular lymphoma. And this all goes back to the point that the immune system of the patient seems to be very important in the management and control of follicular lymphoma. So if you have this diagnosis, you should be looking at evaluating the status of the immune system and also using immunotherapy drugs that leverage the patient's own normal defenses against this lymphoma diagnosis. And lastly, I want to make a final point about the use of certain types of chemotherapy and how they can affect the patient's immune system. As we just discussed, patients with follicular lymphoma may already have a weakened immune system by the nature of their disease. There are certain types of chemotherapy that will further decrease the function of their immune system and could potentially lead to a net negative effect in the fight against follicular lymphoma. For this reason, I ask the patients to discuss this particular detail with their provider and choose the appropriate treatment that is the most logic for their state of disease and the state of their immune system. In summary, if you have a diagnosis of follicular lymphoma, I recommend that you seek attention at a center with high volume and high expertise in lymphoma in general. You must have appropriate staging, including bone marrow biopsy, PET-CT scan. You must make sure that your provider has done absolutely everything to rule out the possibility of histological transformation, and that your provider is taking into account not only the status of your disease, but the status of your immune system in general when choosing the appropriate modality of therapy for your disease.
I want to express our sincere thank you to our patients, to the members of our Mayo Clinic Lymphoma Disease-Oriented Group, to the Mayo Clinic, and to the Goldman Philanthropic Partnerships for this generous gift to produce this series. This gift has an incredible duality in that it goes directly toward enhancing patient care and provider education. We are at a time of phenomenal rapid change in the treatment plans, the biology, and approaches to clinical care in patients with lymphoproliferative disorders. This project will serve to inform. Again, our sincere thank you, and in the words of Dr. William Mayo, quote, "The needs of the patient come first."